Yeah, thanks for the kind introduction. My name is Michael Rasper. I work for the Spital AG and I'm a member of Team Radiologie Plus located in the northern east of Switzerland. And it is now my part to present the radiological assessment of Lipomatis soft tissue masses. I have no disclosures. So the 2020 WHO classification categorizes Lipomatis tumors according to their dignity, which goes from benign to malignant lesions. And in between, we have the so-called intermediate lesions, which are locally aggressive but do not metastasize. And you can already see on this slide that many of the tumors and many of the lesions we will see further on fall into the benign category. So what's the role of imaging and the role of the radiologist in the assessment of lipomatis tumors? First and foremost, we have to decide whether a lesion or a tumor is really a tumor or is it something else like a non-neoplastic alteration, which can be, for example, fat necrosis. We have to decide if the tumor looks rather benign, intermediate, or malignant on imaging. We have to perform local staging, and we should decide which lesions need further workup, which might mean a biopsy, resection, or image-guided follow-up. And as always, we should closely work together with the clinicians who know the patients, who can provide us with information, who did the clinical exams, and of course, with our pathologists. Some diagnostic considerations. First of all, and most important, fat-containing tumors are not rare. They are common lesions and you will encounter them in your everyday practice. So you should know how to deal with these lesions. What you should know if you see a lipomatis tumor is whether the lesion is symptomatic or not. So is it a painful lesion or just an incidental finding? You should know the patient age and of course the lesion location. We usually go for MRI to assess lipomatis tumors, but in some cases, we might also use ultrasound or computed tomography, as we will see later on. And what is our main task as a radiologist is to provide the specific diagnosis of a benign lesion. And if we cannot do so, we have to suggest further workup, which might mean biopsy or tumor resection. What makes the assessment of lipomatis tumors quite challenging is the fact that there is a certain overlap of imaging features between benign, intermediate, and malignant lesions. In fact, there are some imaging features that favor a benign diagnosis, like a small size, superficial location, which means above the fascia, the absence of thick septa, and the absence of non-adipose tumor components, whereas on the other hand, there are features that should raise the concern for a malignant lesion, which is a larger size, a deep location, the presence of thick septa, and what is very important, the presence of tumor components which are non-fatty in their nature and which then usually show contrast enhancement. What you should have if you want to assess lipomatis tumors is some standard sequences. You should have them in your repertoire. What is very important is a fluid-sensitive fat set sequence in the long axis. This might be a stir sequence or a T2 fat set sequence. You should have a non-fat set T1 in the long axis. Of course, we're dealing with lipomatis tumors. You want to see the fat inside the lesion. You can perform these sequences before and after IV gadolinium, and if you do so, you can also do image subtraction. What is very important is a high-resolution, high-quality T2 non-fat set sequence, which should be performed in the short axis or transverse orientation. This sequence is very important for local tumor staging. And what you also want to have is a T1 fat set after IV gadolinium, which should also be performed in transverse orientation or in the short axis. So this is a nice tumor protocol. This is what you want to have. But of course, in many cases, you will not have all of these sequences available because in many cases, lipomatis tumors will be an incidental finding on a scan that was performed for other reasons. So in these cases, you have to decide if the sequences you have are sufficient to provide a specific diagnosis. If they are not, you have to recall the patient and do additional imaging. So let's start with the benign lesions. And the most important is, of course, the classic lipoma, which accounts for around about 50% of all soft tissue masses. It usually occurs in elder patients. They are typically asymptomatic. The lipomas can be located superficially or deep in relation to the fascia. They typically contain mature adipose tissues. They can have some septa, they may have a capsule, and in some cases, they may even contain non-fatty tissues, which then might be, for example, fibrous or myxoid. An important diagnostic pitfall you should know is the presence of necrosis inside a lipoma, because necrosis inside a lipoma may make the tumor look more aggressive than it actually is, and it can then easily be confused with an atypical lipomatous tumor or even a liposarcoma. This is a 47-year-old female patient who presented in our department with a paraumbilical mass. In this case, we decided to perform ultrasound in the first line. What you can see here is a clearly delineated mass in the subcutaneous fat tissue. The texture and echogenicity of the lesion is pretty similar to that of the subcutaneous fat tissue. There are some streaks inside which have a little higher echogenicity, it might be septa, for example. And what is very important, there is no portion inside the lesion that has a different ecotexture or that looks non-fatty. So this is the image appearance, the ultrasound appearance of a simple lipoma. In this case, it's a 70-year-old male patient who presented with a mass in the neck. We performed ultrasound again. And here you see this, again, well-delineated lesion, which has a rather low echogenicity, some streaks inside again. And like in the last case, there is no area inside the lesion that appears to be non-fatty. So again, this is the classic ultrasound lipoma appearance of a lipoma, and no further workup is needed. When you deal with lipomatous lesions in the neck region, you should be aware of a rather rare differential diagnosis, which is the so-called Madelung disease. And in comparison to the clearly or well-delineated lipomas we saw before, this is a diffuse proliferation of mature fat tissue in the subcutaneous tissue layer. As you can see on these images from the literature, it is pretty hard to decide where the lesion ends and where the normal or healthy fat tissue begins. So this is not a clearly delineated lipoma. It is a benign, diffuse proliferation of subcutaneous fat tissue. This is another lipoma case from our department, a 44-year-old female patient who presented with a prepatellar mass. We performed MRI in this case, and you can see that there is a mass in the subcutaneous layer. It has a homogeneous high T1 signal. There are some very thin septa inside. The tumor fully suppresses on the proton-weighted fat side images, and there is almost no contrast enhancement inside the lesion. So this is the typical MR appearance of a simple lipoma, and no further workup is needed. This case is slightly different. This is a 30-year-old male patient who presented with a palpable mass in the shoulder region. We performed MRI, and we saw this subcutaneous tumor, which consists in most parts of fat, as you can see through the high T1 signal. But you can also appreciate that there are parts of the tumor which are rather low in T1 signal, which do not fully suppress on the fat side images, and which show some diffuse contrast enhancement. So this is not a simple lipoma. Our differential diagnosis included lipoma variants, and the tumor was resected, and histopathology turned out to be a so-called fibrolipoma, which means a benign lipoma variant. Another lipoma variant you should be aware of is the so-called spindle cell lipoma. This tumor typically occurs in the upper back, shoulder, or neck region in middle-aged men. The tumors can contain variable amounts of fat. In this example from the literature, it's a tumor with a high proportion of fat, and there are only some small areas which have a rather low signal. and which show some contrast enhancement, but in some cases, the tumor can contain only little fat and other tissues which show rather avid contrast enhancement. And in these cases, it might be pretty hard to differentiate spindle cell lipoma from a low-grade liposarcoma. And if this is the case, you should go for biopsy. Another fat-containing entity you should be aware of is fat necrosis. This is a 41-year-old female patient who presented with a palpable mass in the hip region. We performed MRI, and you can see that there is a subcutaneous lesion which contains fat, which is represented by the high T1 signal again, but the lesion does not fully suppress and signal on the fat-suppressed Dixon image, and it shows some diffuse contrast enhancement, which is pronounced in the outer parts of the lesion. So this is obviously not a simple lipoma. The lesion was resected, and it turned out to be a fat necrosis, which was due to the injection of corticosteroids in this area. And you can easily imagine that in some cases, it can be pretty hard to differentiate these lesions from liposarcoma, especially when there is a lot of inflammation going on in the outer parts of the lesion with contrast enhancement. Another lipomatis entity I would like to present is Lipoma Arborescence, which is represented by a diffuse fatty proliferation of the subsynovial tissue layer in large joints. It usually appears in the knee, but it can also affect other joints like the ankle or the hip. And what you see on the images is a diffuse proliferation of mature fat tissue, which fully suppresses in the fat set images and which is typically located in the subsynovial layer of the suprapatellar recess of the knee joint, and which is, like in this case, accompanied by a large joint effusion. We do not really know what the pathogenesis of this lesion is. It might be reactive in nature or post-traumatic, or it could be even a true neoplasm, and patients are typically treated by synovectomy if they are symptomatic. This is another case of Lipoma Arborescence from our department. Again, you see this diffuse fatty proliferation in the subsynovial layer in the suprapatellar recess. There's a full suppression on the opposed face images and on the fat side images. And again, this lesion is accompanied by a large joint effusion. Another rather rare lipomatis alteration is the so-called fibrolipomatis hamartoma of the nerve, which typically affects the median nerves. The patients tend to be rather young, so the typical presentation is under the age of 30. What you see is a diffuse proliferation of mature fat tissue around the thickened fascicles of the nerve, which creates the so-called spaghetti string sign, which you can nicely appreciate on this sagittal image. As I already said, the median nerve is the most commonly affected nerve. Patients usually present with symptoms of nerve compression or even with carpal tunnel syndrome. And in some cases, like you can see on this image from the literature, the fibrolipomatis hamartoma of the median nerve can be accompanied or associated with macrodactylia. So let's move on to the intermediate lesions. All lesions we saw before were benign, and the important entity in the intermediate group is the so-called atypical lipomatis tumor, ALT, which was formerly referred to as grade 1 liposarcoma. These tumors show locally aggressive growth, but they usually do not metastasize, and there is a certain risk that these tumors or these lesions can dedifferentiate into higher grade sarcomas, and this is especially the case when they are located in the retroperitoneal space. These are images from Technical University of Munich, where I used to work before, and what you see is a mass in the calf musculature of a patient. On the T1 image, you can nicely see that the tumor mostly consists of a mature fat tissue, but here in the upper part, there is a region which has a lower, rather low signal in T1, which does not fully suppress in the stir image, which has some signal alterations in the T2 non-FATSAT sequence, and which shows pretty avid contrast enhancement in the septa and in the periphery. So this is clearly not a simple lipoma. It's a large lesion. It's deeply located. It contains non-fatty parts, and it shows contrast enhancements. And all of this should raise the suspicion for at least an atypical lipomatis tumor. And this lesion was resected and turned out to be an ALT. We move on to the malignant lesions, which means liposarcomas. They can be, for example, pleomorphic in their subtype or dedifferentiated. They usually occur de novo, but as I already told you before, in some cases, tumors can dedifferentiate from atypical lipomatis tumors, especially in the retroperitoneal space. These tumors do metastasize, usually into the lungs, and in case of, or especially in case of pleomorphic liposarcomas, the imaging appearance can be very variable. They can contain little or almost no fat, they can have necrosis, and they can have hemorrhage as well. This is another example from the Technical University of Munich. There is a large tumor in the upper leg of a patient. On T1, you see that there is almost no fat inside the lesion, maybe a small portion down here. The tumor has a very high and inhomogeneous signal in the stir image. There is some edema around the tumor. And T2, there is high signal, also pretty inhomogeneous, and there is very avid contrast enhancement, very inhomogeneous contrast enhancement, which should raise the suspicion for a high-grade or rather dedifferentiated sarcoma, and this turned out to be a pleomorphic liposarcoma. Another subtype of liposarcoma is the so-called Mixoid Liposarcoma, which tends to affect rather younger patients. These tumors have a high risk for local recurrence and for metastasis. And similar to the pleomorphic sarcoma, imaging appearance can be quite variable according to varying amounts of fatty, mixoid, non-fatty, and non-mixoid components. And again, there can be very little or almost no fat inside the lesion. Sometimes you only see a little fat in the septa or small noduli of fat. And this is also the case in this patient. On T1, there is almost no fat inside the lesion. The signal in the stir is pretty high and very inhomogeneous. The same holds true for the T2 weighted sequence. And this is what we expect from a mixoid tumor according to the high water content. And after IV gadolinium, you see this very avid contrast enhancement, which is diffuse and pronounced in the outer parts of the lesion, again, suggesting a rather high-grade and rather dedifferentiated tumor, which in this case turned out to be a mixoid liposarcoma. Liposarcomas can also affect other parts of the body, like the retroperitoneal space. These patients tend to be elder. The tumors are typically large at presentation. They tend to encase organs, which makes total resection of the lesions pretty challenging, and which leads to a higher recurrence rate and a worse prognosis. There are different subtypes again. The tumors can be differentiated, dedifferentiated, pleomorphic, and so on. This is an example from our department, a patient who presented with diffuse abdominal pain. In this case, a CT scan was performed, and you see that there is a large mass in the retroperitoneal space, which contains of different components. Here on the right is a component which shows a rather low density, which means there seems to be some mature fat inside. So this seems to be a rather differentiated fatty part of the tumor, whereas on the left side, there is a dedifferentiated part, which shows almost no fat inside and which shows avid contrast enhancement. And this is the more aggressive part of the tumor, the dedifferentiated part of the tumor. And this is the part of the tumor you should guide your biopsy to if you do so. And this is also the component of the tumor which is important for the prognosis of the patient. Another case from our department, a 66-year-old female patient with a retroperitoneal liposarcoma. This tumor seems rather dedifferentiated. There is a lot of contrast enhancement. There is some tumor necrosis inside. Maybe there is some well-differentiated tumor fat here in the anterior parts, but it's sometimes hard to differentiate this well-differentiated tumor fat from the local or normal tumor retroperitoneal fat. The patient underwent surgery. The tumor was resected, but unfortunately, only 3 months after resection, the patient presented with a local tumor recurrence right inferior to the left kidney. Let me say a few words concerning the local staging of lipomatis tumors. If you're more interested in this, I highly recommend this radiology paper from the Munich group. The group analyzed the neurovascular encasement in 174 cases of sarcomas. And what they found out is what you may already know, or which might remind you of pancreatic cancer, because the important cutoff is again 180 degrees. So you look at your axial T2s, which again should be of high quality and high resolution, and you decide whether or not the tumor encases the vessels or the nerves for more than 180 degrees. So these are 2 examples from this publication. On the upper image, there is a tumor in the thigh region, which has contact to the sciatic nerve, but you can easily see that there is no encasement of the nerve for more than 180 degrees. And intraoperatively, the nerve could be dissected from the tumor, so there was no nerve infiltration. This is another case of a sarcoma in the popliteal fossa. In this case, you can see that the popliteal artery, which is here, is encased by the tumor to slightly more than 180 degrees, while the popliteal vein and the nerves are not encased by the tumor. And intraoperatively, it turned out that the artery could not be dissected from the tumor, and histopathologic workup showed that the artery wall was infiltrated by the tumor, while the popliteal vein and the nerves were not infiltrated. So to come to the end, I would like to present a short workup suggestion for lipomatis tumors, which is from a 2017 publication. If the lesion is located in the retroperitoneum, you should usually go for biopsy. If it's a superficial lesion and if it's pure fatty or predominantly fatty on image, you usually need no biopsy before the tumor is resected. If it appears rather complex or has only little fat inside, you should go for biopsy. If the lesion is deeply located, which means below the fascia, there's a size criterion. If the lesion is larger than 10 centimeters, it should be excised, or you should at least perform biopsy to have an MDM2 status. If it is larger than 5 centimeters, but in a special location, like in the buttock or thigh, the same is true. If the lesion does not meet the size criterion, but it has some concerning MR features, as I showed you before, like septa, which are thicker than 2 millimeters, or non-fatty nodules, the lesion should also be excised, or you should also go for biopsy. If there's a deep fatty lesion which has no suspicious criteria of a well-defined liposarcoma, then the case should individually be discussed in an interdisciplinary tumor meeting. The patient should be reassured. If he's keen for surgery, the tumor should be resected. If not, the tumor should be monitored clinically and by imaging. So to sum up, we can say that lipomatis tumors are frequent lesions. You will encounter them in your everyday practice, so you should know how to deal with them. What you have to offer is the specific diagnosis of a benign lesion, which in most cases means lipoma. If you cannot do so, the lesion needs further workup, which might mean biopsy or resection. And what I highly recommend is that every lesion which is more complicated than a simple lipoma or lipoma variant should in general be seen in a specialized sarcoma center or should be discussed in interdisciplinary boards to find optimal treatment for the patient. So many thanks for your attention. If you want to see this talk again or even other talks, you can visit our Team Radiology homepage. Thanks.